Problem solvers. Let me give you that again because the recording had not started. Welcome back, clinical problem solvers, to another Friday edition of Robbie Loves Reza.
Yes,
Robbie, how are you?
I'm doing very well. Actually, that's not 100% true. It's funny how I feel a little bit of like shame telling you all that I got my COVID booster. And the reason I feel shame is because I know that there are 6 times more booster doses given than the first vaccinations in the world. And that's something to be ashamed about. It's not my fault, of course. And I'm very conscious of the fact that there's tremendous privilege in this country, and to be able to have a booster is amazing. And people who listen to this, or people who know people who know people who listen to this, may not have had even access to their first shot. But here I am after 3, and I will tell you why I'm honored to have had 3 shots. Hoy, it's heavy. So this morning I felt like I was hit by a train, but now here's the solution. I feel like I'm deviating from medicine. The fix for COVID booster-induced myalgias is yogurt and tea, and some licks by your dog on your nose and face. The combination of that has made me feel much better. How are you?
I mean, I'm struggling to find this unmute button, but otherwise, doing really well. Excited for today's case, and I know it's going to be challenging based on what I've been told, though I don't know what the case is.
Yeah, we have a very special presenter today, Julia from Rio, who has worked very hard to prepare this case. And Julia, do you want to unmute and introduce yourself to the VMR crowd?
Sure. Hi, everyone. My name is Julia. I'm a third-year medical student from Brazil. I'm super excited to be here. I admire this group and this team so much. I also like to thank Kara. She told me she wouldn't be able to be here, but she really helped me prepare this case. And also Rabi and Reza for this amazing opportunity. I hope we can all learn from this case, from this challenging case. Yeah.
It's challenging. Well, Julia, you know, I got wind of all the effort that you were putting in, and I'm very, very grateful for you coming here. I don't think I told you I would ask you this, but I think it's important for us as a group to reflect on it, which is tell us how you feel right now.
If I may be honest, I'm super nervous. This is my first presentation in English, so the language is already something to be nervous about, to pass on all the information needed. So yeah, that makes me nervous, but I'm also really, really happy and grateful, like through the roof happy. I hope it will be fun. Yeah.
Yeah, you know, I understand your anxiety. I think anytime that I have to speak publicly, even though it's been thousands of reps now, it's still a little bit anxiety provoking. But especially if you have to speak in a different language, that makes it to another level. I just wanted to say that I think I cannot wait for you to feel what one tends to feel at the end of this, which is you finally feel like you've done it and you've climbed the hill. And I'm sure Maria and Rafa, and I see Franco here, can attest to that arc. And so I look forward to you feeling that way. I know Reza and I can't wait to tackle the case. And hopefully you'll be smiling more than us as we flop on this very hard case. All right, take it away, my friend.
Thank you so much. So I divided this a bit differently than usual. The first aliquot, me and Kara, we agreed that it should be the chief complaint all along, because it is not that common for us to see, given the time frame of the symptom. So the patient, he presents with 1 year of progressive constipation and abdominal pain.
Ooh, I can see why you would say that. 1 year of progressive constipation and abdominal pain is very, very unusual. And maybe what I can do is to try to describe the lay of the land, and then pass the mic on to Reza. I think it's really helpful that we focus on that we focus on the chief concern. The very point of the chief concern is to let the patient triage to us what they think is the most important problem. And more often than not, they're right. And so I would be I would pay a lot of attention to what the patient chose to say first. Did they choose to say constipation first, or did they choose to say abdominal pain first? Because if the constipation is more bothersome to them, I would probably use that as my schema. If the abdominal pain was more bothersome to them, I would probably use constipation as a modifier of abdominal pain. In reality, you're operating in both tracks, and you're going to assume that they're related, but you don't know which one is the dominant one. Most people who have abdominal pain that is severe enough choose not to describe in the first few words the presence of constipation. So I'm inclined to, just because the constipation has risen so high up in the patient's concern, rather than it being something that they just randomly tell you 5 minutes into the conversation, to focus on. And so the constipation is actually at the root of it very, very simple. There's something not moving through the tunnel of the GI tract, and that is either because the tunnel is blocked or the very mechanism required to propel stool through the GI tract is impaired, meaning there's a blockage or the neuromuscular access is not working. Can a blockage exist for a year? Yes. Probably not, but subacute to chronic obstructions are real, especially intermittent ones. The most common causes of impaired neurologic motility are actually nothing to do with the neurosystem. They're medications that patients can take, like opiates and iron, and electrolyte abnormalities like hypercalcemia. But that's where my mind is at. I'm curious what Reza is doing with the tension of both the abdominal pain and constipation. Where else your mind is going, my friend?
It's going nowhere else. Very excited for this case. And Julia, the reason I'm so excited is because this is a chief concern we don't often encounter. And for it to be the foreground, that is constipation, is telling me that there's a lot we're going to learn during the exercise and then after the exercise. So my only discussion here is thank you for bringing this chief concern to VMR.
You're welcome. I hope it'll be a bit more clear later, but I'm finding it interesting already.
Please give us some more information, Julia.
Okay, so the second LQAT will be a bit longer. It will include both the HPI and the rest of the history, but please feel free to interrupt me if you prefer that I do it separately. So for the HPI, he's a 19-year-old male with slowly and progressive constipation for about a year, right? And when he first started, his constipation was resolved with light laxatives, but with time, he needed stronger ones until he went on for about 3 weeks with very low frequency of evacuation, as he noticed. And he's also noticed some significant abdominal distension in the same period. Plus, after the first week of this evacuation difficulty, he started to experience some stabbing, sudden onset, diffuse abdominal pain, which was also progressive at worst 8 out of 10 when he got to the ED, non-radiated and continuous. Also, 3 days before heading to the hospital, he began to experience 2 to 3 episodes of horrible smelling brown colored vomitus, and 2 to 3 episodes a day. And he also claims weight loss of around 7 kilograms that year. And lastly, he had loss of appetite, but no changes in the food in his diet, no food trigger, no diarrhea. The feces aspect was always either normal or hard. No urinary incontinence. He had no recent travel, trauma, or surgeries, and also no dysphagia. Okay, so I'll move on to past medical history. So for childhood illnesses, we have pneumonia and chickenpox, plus it had EBV at 15 years old, and type A hepatitis at 17. He didn't take any regular medications. Now, concerning family history, his mother was 55, she's alive, and type 2 diabetic. And his father is 58 and also type 2 diabetic. He has one other older brother who's 23 and healthy now, but his mother did remember that the patient's brother experienced some rash, fever, and vomiting during childhood, which was spontaneously resolved. As for social history, he's originally from a countryside area on the north of Brazil with not much access to healthcare. And he now moved to Rio with his mother and brother. He always lived with them, but also in the countryside of Rio de Janeiro, where he was admitted. And he hasn't been to his hometown since 2015. If you need me to repeat something, you can ask.
Well, I think you're still muted, buddy.
I just need a couple more years and I'll learn that. But who's scribing today? Maria, do you have any questions before I tackle this? Okay. Wow. What an aliquot. You're talking about nervousness, Julia. I'm starting to get palpitations and diaphoresis from this information. Robert, we have to tackle this together. And maybe I'll just speak briefly and then just pass you the mic and feel free to go back and forth, PRN. Right away, there's two issues here. One is, what are we going to do acutely? Like, what's emergent? And then the other is more analytical. So system one, reflexive reaction, like what am I concerned about? System two, let's think about it. Let's go through the diagnostic journey. For the system one, actually, maybe I'll pass the mic for Robbie to discuss and add whatever he wants. What I'm thinking, Robbie, is abdominal distension, vomiting, abdominal pain, bringing to mind obstruction, and like how you tackle that in the emergency department, because Robbie works in the ED. The part I'll tackle, which I know you'll add to that as well, is more the system two, like what's going on here? How do we explain this patient's presentation? The system two, the analytical part, is when you're having a nice cup of coffee and you've taken care of all of the emergency stuff. This, we often emphasize on our podcast the power of tempo. Something that we don't emphasize as much, but deserves equal attention, especially when you're talking about symptoms that are subacute to chronic, like this patient, is sequence of events. Sequence of events is critical when you're trying to understand a chronic disease. So if we start the sequence of events here, everything started with constipation. So this is where our diagnostic journey starts. And it's hard to separate the rest of the presentation from the constipation. Why? The severity of the constipation, one. Two, the young age of the patient. These are two red flags where constipation deviates from a benign cause like hypovolemia or dehydration. To give you an example, I was a resident once I guess Robbie was a resident once too, but during my residency at UCSF, in my third year, I was on the cardiology service and I was responsible for the code pager. That day, I didn't drink any water. That day, I became constipated, severely constipated. So that's a benign cause. There's no red flag there. There's a good alternative explanation. And most people who have constipation without a red flag, and just to complete that list, it includes systemic causes and refractory to treatment. That's another. So young patient, refractory to treatment, these are red flags. If there are no red flags, think irritable bowel syndrome, the constipation phenotype. So then let's layer onto what Robbie said. Obstruction is a rare cause of constipation, and Robbie's going to talk about obstruction. Yes, we will consider that DDX, but I think we have to also consider decreased motility. And so we'll look at the hypokalemia, hypercalcemia. We'll make sure that the patient isn't taking any over-the-counter substances that could lead to constipation. And then, based on the physical exam, we might actually consider rare causes, especially given the patient's, demographics. We can consider some organisms. For example, in South America, Chagas disease, caused by Trypanosoma cruzi, trypanosomiasis. One of the main manifestations is gastrointestinal, and it can lead to constipation. I'll leave it at that, but I'll just say I'm concerned about the constipations. There's alarm features. I'll be looking at the patient's electrolytes, and then I'll be considering less common etiologies, and the physical exam will be able to help navigate that as well.
I love that. I think that's superb. And I think the breakdown of system 2 is amazing. I think in terms of system 1, you know that the color of the vomitus suggests that there's feces in it, especially given the history. And so that tells you that there's a very high chance that the small bowel is involved. And before you make the appropriate assumption that what has happened is the obstruction is so bad that there's been fecalization of the small bowel, you have to stop and make sure that you're not missing the possibility that a fistula has formed. So basically the two ways for poop to make it to the small bowel in a patient like this is it just backs up, or the colon gets so distended, it touches the small bowel, causes a fistula to form. And so you have an entero fistula, and that mediates the passage of feces into the small bowel. And so in this patient, you'd probably get a KUB, you'd probably see distended loops of bowel, which you would follow with an NG tube for relief and for a diagnostic clarity. And then it's all about imaging. The role of PO contrast in these cases is diminished given the better improving utility of IV contrast. You also have to be careful not to administer PO contrast, specific kinds of PO contrast in the setting of the possibility of perforation, which is low here, but something you should think about. So yeah, I think the simple ER version is NG tube and imaging, in addition to the electrolytes and stuff like that. All right, Julia, back to you.
Okay, everyone. So now I'll move on to physical and labs. So his temperature was 98.42. His heart rate was 90. His BP was 120/80. His respiratory rate was 20. His O2 stats were 98. Concerning genitalia, there were no apparent distress. He did have pale palpebral conjunctiva, 2 crosses out of 4. The CV was normal, S1 and S2, and no murmurs. His pulmonary exam showed normal bilateral vesicular sounds. He was neurologically alert, he followed commands, and his reflexes were intact. His skin showed no lesions, cyanosis, or pallor. Now for abdomen, it was distended with highly reduced bowel sounds, diffuse pain upon palpation, and was positive for gardening, but no rebound. And also in rectal exam, there was hard stool felt in the rectal vault. Yes, so I'll move on to labs now. I think that might help. There was elevated white blood cell count of 24,000. The neutrophils were 80%, monocytes 2%, lymphocytes 17%, eosinophils 1%, and basophils 0%. He had an LDH of 7,000, lactate of 6, pH was 7.15, bicarbonate was 13, PCO2 was 34, his fasting blood sugar level was 88. serum calcium was 9.3. His potassium was 4.2. T4 was 1.3. TSH 2.7. He was tested negative for HIV, negative for syphilis, and in summary, almost all normal except for his white blood cell counts, arterial blood gas analysis, LDH, and lactate.
Well, you know, I'm going to swipe away from that and focus on the exam and leave for the labs for Reza to digest. And I will tell you one thing about the exam. It's reassuring that a syndrome that has been going on for a year has not picked up its tempo, at least in terms of the vital signs, but it has left its signature in terms of the possibility of anemia of chronic disease, but also mechanisms to entertain also in this patient is GI blood loss, given the GI focus of the presentation. I think it's really amazing, Julia, that, well, two things. I think the way you're telling the story is amazing. I think you're breaking it down clearly such that Maria can easily keep up with you. And you're summarizing the pertinent abnormalities, which are really helpful. But I also commend you for doing this rectal exam because it changes the calculus significantly. It's much more probable now that you found stool in the rectal vault that there is a motility problem. Because if there was an obstruction, the only obstruction that would still leave a significant amount of stool in the rectal vault is this obstruction right then and there. So the fact that the stool is making it to the rectal vault enough that you appreciate it just tells you there's a traffic jam behind you and things aren't being propelled well enough. While that's not, you don't want to anchor definitively on a physical exam for almost anything. The probability of a obstruction has been reduced unless that obstruction is right there. And so what kind of obstruction is right there? Remember, this patient's 19. And so the possibility that he has a congenital issue showing up at 19 isn't zero. So this might make me prioritize motility issues, but also entertain the late presentation, which has been described of Hirschsprung's disease, which is not obstructive. It really is also kind of in the motility category of impaired neuraxis there. But I think the labs tell a very different story, and so I'll pass the mic to Reza.
Robbie, I think that we should dissect these labs together because it's so rich. And I really love the point you made about there definitely being decreased motility based on the stool in the rectal vault, though not excluding the possibility of obstruction. Since the last time I spoke about eosinophilia, maybe I'll leave that for you to speak about this time, and I'll tackle some of the other lab findings. Again, system 1 and system 2. Right now, you see a lactate of 6 in someone with a distended abdomen. You have to be concerned with a leukocytosis. What should you be concerned and guarding? I'm adding layer and layer and layer. What should you be concerned about? A perforation. Why do people perf? Well, common causes of perforation include peptic ulcer disease, diverticulitis, or dilation of the colon. And here we know that the patient has a distended abdomen, there's stool in the rectal vault, and we're dealing with a motility issue. And since we're concerned for perforation, where we go on our perforation schema is directly to dilated bowels. So what causes dilated bowels? It really comes in 2 flavors. One is obstruction, and the other is toxic megacolon. Obstruction, you can think about cancers, adhesions, strictures, hernia, volvulus. When it comes to toxic megacolon, you can think about stuff like C. diff or an ileus from any cause. So now the question becomes, why? Why does he have decreased motility? And does he have a perforation? I think the other thing I need to comment on here is the LDH. By the way, with the vomiting, you're losing acid-rich content. You're activating the renin-angiotensin-aldosterone system. So you can have a high bicarb, although I'm not sure about the pH being low would counter that argument. So I don't know if the pH was 7.1. So I know there's a lot of question marks there, but maybe Julia, you can put the pH in the chat for us to clarify what that is. Anyways, with the LDH, we have an LDH pyramid. And at the great, I think, utility of pyramids is it allows you to apply frequency of disease so that you put your cognitive energy at the most common cause. At the peak of this pyramid is hemolysis, but there's no marker really here for hemolysis. If you look at the hemoglobin, the bilirubin, the AST, the second layer is there organ infarction, liver, kidney, muscle, or heart? And then there's no strong evidence of that, though. I would caution you because the patient has guarding. The patient has a distended abdomen. Could there be some bowel twisting on itself causing increased cell turnover? There could be, and you have to consider this, despite it being very high. Then the last layer is like metastatic adenocarcinoma and lymphoma. So again, I'm going to pass the mic to Robbie to just add to that, talk about the eosinophils. You see a distended abdomen. You see brown stuff coming out of the mouth. You see stool in the rectal vault. You see guarding. You see lactate. You got to think perforation. You got to think dilation. You got to think a serious consequence.
I love it. I have nothing to add. I think the EOs here, the truth about EOs is I'm not sure if they represent that 1% being rounded up or rounded down. And that makes a big difference because the total white count is so high. So 1% of 24,000 would be 240, if I'm not doing my math wrong, which is higher than you might expect if patients this critically ill. But for me, I would track that.
Oh, I'm sorry, Robbie. I thought it was 17%. My apologies.
Oh, no,
or I would have left that for you to discuss.
Yeah. We're so primed to think about eosinophilia given like the Chagas and other parasitic diseases. But the truth is, I don't think anybody was expecting, whenever somebody has a year of symptoms, to assume that their LDH is 7,000 is crazy. So clearly there's a surprise that awaits for us. So I can't wait for Julia to uncover that surprise.
I should tell you now that the labs also made the doctors a bit confused, but I do have an imaging test, an abdomen CT was made, and then after that I'll give you the test that will reveal the diagnosis. So I'll show you now the CT, if I may share my screen.
Yeah, go ahead, go for it. You're a co-host already too.
Okay. So here. Can you see it?
I think the screen that you shared is the Zoom. Yeah, you just have to click on that. Yeah, and now we're seeing it. Yeah.
Okay.
Oh my God.
Yeah. And now there's also this one. Stop sharing. Yeah. Okay. I stopped sharing my screen. I'm sorry. I'm kind of confused with Zoom sometimes.
No, you did it.
Yeah.
Yeah,
Okay.
yeah, no, go ahead, Julia. Sorry.
No. Yeah. That was it. And you can play your final hypothesis now, and then we'll move on to diagnosis.
Yeah, I think I didn't see an obstruction. You see that there's stool filling the rectal vault, and so I think we're squarely in the world of pretty sinister, severe refractory constipation. And the schema for that is on our website. You can take a look at it. And I think in this case, what does the LDH and lactate mean? It means that you need to fix this problem very quickly, especially since there was an extra focus of bowel involvement to implicate something else. And often when we say, an LDH this high can't come from bowel dying so much, I don't know if anybody has seen this much bowel being compressed all the way up to the stomach. I think in terms of reinforcing the list that Reza made in terms of electrolyte issues, none, meds, none. Um, Neurological diseases, the list is pretty long, but includes amyloidosis, acute intermittent porphyria, Chagas disease, lead toxicity. There's also diseases that exist in the muscle itself, which would be things like hypothyroidism, scleroderma, and eosinophilic gastroenteritis. The epidemiology here is most suggestive of Chagas, I would say. The clue that we might have seen on imaging is megaesophagus as well, which I didn't see. But I'll tell you some sneak CPS pearls is the fact that Julia early on even explicitly said there is no dysphagia. Got my heart to skip a beat here. A deliberate pertinent negative may have been a subtle clue. But I think more importantly, what other clues might have been left along the way is what his brother had. His brother had what might have been an acute episode of Chagas that self-resolved, and unfortunately might also be at risk of complications. The thing that's unusual for me is how young he is, because though I've never seen Chagas, I've done a small amount of reading on it, and my understanding is that constipation usually takes 3 decades or more to kick in. So the fact that he's this young has me question that diagnosis to some degree, and entertain the possibility of Hirschsprung's disease, which I actually have no idea how people diagnose. I would guess it's a diagnosis of exclusion, but I don't know. So I think in this case, what do I know? If I were alone taking care of this patient, I would know that I need to potentially involve my surgical colleagues and decompress this patient from above and below. And for the exercise, get an EKG to rule out cardiac Chagas and to look at the serology for Chagas. But I would also call, if I saw this in real time, I'd be on the phone with Reza before I did any of that to get his input. So I'll do the same right now.
Too kind. Julia, I have zero to add. Very excited to learn from you, my friend. And you really have me at the edge of my seat. And I want to say one more thing. You did a phenomenal job presenting this case. So bravo to you, bravo to Kara. Thank you both so much.
I'm the one to be thankful for this opportunity. And if you don't have anything else to add, I could move on. So Ravi, you nailed it at your last point. They did do Chagas serology, and because of the presence of host IgG against Trypanosoma cruzi antigens, that plus the image plus family history epidemiology, it led to the diagnosis of Chagasic megacolon. Yeah.
Wow, incredible. Tell us more. How did the patient do? What did you think of this diagnosis? How did you react to it? The floor is yours. What did you learn? Tell us where you're at.
Well, I haven't followed him after because he was sent to a reference center for treatment. He was indicated for surgery. I don't remember exactly. I think he needed a full colectomy and ileorectal anastomosis. But other than that, I did bring some teaching points about Chagas, if you would like me to. Okay. So let me just get a note here so I don't get confused. So first, I would like to add what happens with this chronic Chagas GI manifestation, like what happens in the body, is that our enteric nervous system is degenerated, the myenteric plexus, and so there's a reduction in the number of intrinsic neurons, which causes autonomic dysfunction, right? That could be ultrastructural abnormalities in the remaining neurons, in the intramural ganglia of the gut. The mechanism itself, it's highly unknown. It could be immunological, which is what the most well-supported evidence suggests, or it could even be a low activity chronic infection, with no detective parasites on the blood. So that's why it is still a risk for transmission through blood and organ donation. Secondly, the patient could have also presented with a lack of relaxation of the oops, sorry. I'm not seeing the chat, but can I go on? Okay, sorry. Of the internal sphincter of the anus, which could be detected through manometry. Also, some studies have demonstrated the absence of rectoanal inhibitory reflex, which could be mistaken by Hirschsprung's, is that how you say it, disease? And it wasn't our patient's case, but it could be associated with other GI manifestations like the esophagus or the most famous complication, which is cardiomyopathy. And lastly, it is important to say that those big syndromes of chronic Chagas disease can appear decades later. The patient's case was a bit unusual because, like Ravi said, he was 19. And I'm really grateful that they thought about it and that were able to diagnose this because he was too young. He might have caught it from childhood because of his brother symptoms. And this could be manifested without any detectable parasitmia. And the acute phase could either present itself with the main signs of Chagas that we know, like the Romanon sign, but there could be also very non-specific symptoms, or it could even go by asymptomatic sometimes. So that's kind of what I brought to summarize what's going on with the patient and what might have happened to him.
Julia, thank you so much. What an epic journey that you took us on. And I think this is one of the advantages of global VMR, for us to actually be able to go through an exercise. I know this is a real patient, but a simulation as if we were there in Rio taking care of the patient is only making us more prepared when we have such a patient present to us. Because they talk about something in clinical reasoning being context specificity, being that you're more likely to diagnose conditions and that you're most familiar with in your environment. You're allowing us to break that wall. And so that if a patient comes, we'll be ready. That's my take. Robbie, anything to add?
You know, now I'm gonna go send Chagas on every constipation patient at the VA. I'm kidding. No, not at all. I think your presentation here is absolutely superb. I know the effort that you put into it and the story you told and the impact it's going to have. Impact is massive, you know, because we don't think of these things, see these things. And you may ask, well, what is the impact? The impact for somebody practicing in the United States isn't, oh, I'm going to master Chagas. It's reinforcing the idea of thinking, if there's no obstruction, go neuro. And in Brazil, neuro is Chagas. In the United States, neuro is usually older adult with amyloidosis or with AIP or something super rare. So why do we need to learn why is the gold standard in medicine to try to learn everything? It's because even if you don't see it, it allows you to understand the concept that you're studying better and better and better. So everyone who is exposed to Chagas, you've reminded them of what the disease is like. For everyone who'll never see it, you've reinforced the idea of what a schema for constipation should look like. But the truth is, because of global warming, everybody's going to see Chagas, so you're preparing us all anyway. So thank you. It was a real treat.
It's
all
one
right.
of 5 neglected tropical parasites.
That's
for sure. Yeah. Don't ask me what the other 4 are. I think I read that on the
I was
CDC
debating whether I should do it or not. I was like, no, don't do it.
You know not to do stuff like that.
All right, Maria, take us home, please. Oh, I think it's Rafa, right? Sorry, I couldn't. Oh, there we go.
I could never scrap that fast. Also, thank you, Julia, for the case. Really, really interesting. And thank you for putting it together. Like the first time that I put together a case in English, oh my God. Reza had to go with me like for a week. And he was like, no, Rafa, we have so much to fix here. So I know the struggle.
And Rafa, do you remember you got upset that I got the DX early?
And you were like, he only read the case. I didn't give him the final diagnosis and he was able to reach the final diagnosis. I was like, oh my God.
No, that's not to brag or anything. It was just a cute moment we had.
So we had this patient with progressive constipation, abdominal pain, and Ravi reminded us to actually pay attention to what the patient say first, because we have to have it on the foreground most of the times. And then when it comes to constipation, we can divide that into two buckets, or it could be due to obstruction or impaired peristalsis. Obstruction, many etiologies could lead to that, including fecalease, hernia, adhesion, volvulus, neoplasia. When it comes to impaired peristalsis, we thought about medications like opioid, diltiazem, antacids, especially those who contain aluminum, and anticholinergics, iron, electrolyte abnormalities like hypercalcemia and hypokalemia, infectious causes, which was the case here, like Chagas leading to megacolon, but also genetic defecation that is usually associated with neurological disorders like Parkinson's disease that leads to impaired pelvic muscle floor relaxation. But we also thought about things like lead toxicity. And then we saw that this patient had hard stools found in the rectal wall, and we thought that since the stools were able to get to the rectal wall, probably it was due to impaired motility, the obstruction of this patient, unless there was an obstruction in the rectal vault itself. And then we thought about that this patient had elevated LDH. When we thought about hemolysis, less likely because there was no elevated AST or bilirubin. Ischemia, we also thought about that, and neoplasia like lymphoma. And then finally, which was the diagnosis, we thought about Chagas. Chagas, the most common manifestations include the heart and NGI. Heart could lead to dilated cardiomyopathy with decreased ejection fraction leading to heart failure, but also right bundle branch block, arrhythmias like atrial fibrillation. When it comes to GI manifestation, we have to think about megacolon, leading to slowly progressive constipation, but also megaesophagus and achalasia. So thank everyone. I hope to see everyone tomorrow on Global Virtual Morning Report, and we're going to have Mayor of Rochester Internal Medicine Residency Program with us.
That's so awesome, Rafa. Great job teaching. And I just learned a cool pearl. This is probably the most important thing to take away. April 14th, which is 11 days after my birthday, is Chagas Day. I just learned from the CDC. April 14th is Chagas Day.
I don't think we should call it April 14th is Chaga Days. I think we should say 11 days after Reza's birthday. That's every day. All right, y'all. Have a great day. I'll see you tomorrow.
It also
Bye,
might be the
thank
two-year anniversary of VMR too.
That's right. Wait,
Pretty
Who
close.
cares?
Bye.
No, I'm just joking.
how many days after Reza's birthday is VMR? That's the key question. All right, y'all. Take care.
Ravi, sorry. Can I just say something before we go?
Of course. Please.
I'd like to thank you all so much again. I'm like flying in the clouds. I'm like so happy. So thank you so much for the opportunity. And you guys are really important for medical students and clinical reasons. So important. And thank you. Okay, that's what I meaning to say.
Very, very kind of you. I have two things to respond to that. One is I hope you join us more and more and bring us all your wonderful cases. And I'm already going to reserve Reza's birthday as the day you present as a special moment. Alrighty, bye.
I'll be there. Bye.
Looking forward to it.